we're delighted to have Cynthia Ramierez here. She's a psychologist, clinical psychologist who has her own practice, but she has worn the hat of a researcher, a professor, and a clinician. And that's rare that we get to have somebody like that in our presentation. Let me give you a little background on her. She received her doctoral degree in 2003 and immediately moved to Quito, Ecuador to be close to family. And she was a professor there at the Universidad de San Francisco, where she ran a private practice. Well, then she came back to Atlanta in 2008 for a postdoctoral fellowship program at Emory University and became a licensed in the state of Georgia. The reason we invited her here is because she was one of the key people involved in a very interesting study at Emory University School of Medicine. She was involved in fascinating research, which is as a member of the faculty at Emory's Department of Psychiatry and Behavioral Science, where she was associate director of the Emory Child and Adolescent Mood Program, better known as CAMP, and she was the director of the DBT program there for adolescent and young adults. This is sort of an interdisciplinary clinical research program targeted at improving or identifying and improving best practices for children and adolescents with mood disorders. She recently left Emory University to start her own private practice and allowing her to focus on her priority of providing typical researcher evidence-based treatment to young people struggling to manage their mood and emotions. She specializes in CBT, cognitive behavior therapy, and DBT with adolescents and adults. Her research interests include empirically supported treatment for depressed, anxious, and emotionally dysregulated adolescents and Latino mental health issues. Needless to say, Dr. Ramierez is fluent in Spanish, so she's going to share some of our research with us today, which we're very delighted to have. Cynthia? If you would put this on, let me get out of my thing, and I will pull you up here.
Okay. Can everybody hear me okay? Yeah? Well, thank you so much for having me here. Yes, I was at Emory for many years and just last year left to do private practice. And so what I'm going to be doing today is presenting a little bit of the research that I did while I was still at Emory that was really largely driven by the students who worked with me, right? So I did a lot of kind of the administrative directing piece, but really my students were the ones who came up with all the great ideas. So I put them on here as well. I'll be presenting some of the research that I did with Megan McCallum, who's now at Brown, and Colleen Capworthwaite, who's now at Duke. So they have moved on, but have done really some wonderful things. So this is going to be the outline for the presentation. We're going to go over a little bit more of the biosocial theory of emotion dysregulation. And then I would like to present some research results examining the role of parental invalidation on emotion dysregulation. We're going to also do a very quick overview of DBTA and skills training for adolescents who struggle with emotion dysregulation, and also look at some of the research results examining different ways that you can provide skills training for adolescents and their caregivers. So as you know, BPD is characterized by persistent emotion dysregulation, impulsivity, interpersonal problems, and identity disturbance. And this is something we've been saying all along here since early this morning. It isn't typically diagnosed until adulthood. And we know that the earlier you diagnose BPD, the better treatment response you're going to get, right? So being able to accurately identify individuals who are at risk for developing borderline personality disorder and then providing the treatment early is really what we want to aim for. We reviewed a little bit earlier what is non-suicidal self-injury, but I just want to say again that NSSI, for short, really is an important predictor or precursor to BPD. Okay, and you can see this starts quite early. So we have patients who struggle with some form of self-injury from early childhood, and sometimes it's biting, scratching, or hitting themselves. And that will progress to cutting or burning or some other kind of more tissue damaging type behavior, okay? And there's lots of reasons that people identify as motivators for self-harm. Some of them are internal and some of them are social. These are the 4 primary reinforcers that we've been able to identify. The automatic ones, which are the internal reinforcers, that's to create a desired physical state. So for example, if someone feels empty or numb, self-harming might help them feel something, and sometimes something positive. Negative reinforcer in an automatic state would be to reduce tension. I feel angry, I feel anxious, I feel overwhelmed. Self-harming helps me calm down. The social reinforcers include getting reactions or attention from other people, not in what most people would identify as being manipulative, but is very much a way to say, I am hurting. You don't see how badly I'm hurting. I need you to see how badly I'm hurting, all right? And sometimes negative, right? So if I'm self-harming, if I'm suicidal, they won't make me go to school, right? I won't have to face it. Now, when most parents came in to see me initially, what do you think most parents identified as the number one reason that their child was self-harming? For attention. It's a cry for help, okay? And actually, Knock and Princeton have done some great research, right? Identifying what the principal cause or motivator is for self-harm, and what do you think the kids say?
Number 2, automatic reinforcement.
That's right. To reduce tension, to reduce negative affect or emotions. They are using this as an emotion regulation skill, right? So the emotional pain is so severe that they need to do something like self-harm in order to get some relief from the emotional pain, okay? Now, biosocial theory, Jenny mentioned this when she was up here. Whenever you are part of a DBT program, you get introduced to the biosocial theory of emotion dysregulation. So did everybody get a crash course on this at some point? Okay, all right. The idea is that you have kids who are biologically predisposed to be more sensitive. Okay, so those are the kids where the seams, everything feels kind of aversive. Noises are too loud, too many people, don't touch me, that's too much touching. Reactivity, so you have a very pronounced response to something that's emotionally stressful, and then it takes them a while to calm down. Right? So it takes them a while to get back down to baseline, and that leaves them pretty vulnerable for the next stressful thing that happens. And when you put a kid like that in an environment that is very invalidating, that communicates to them, what is wrong with you? Why can't you get it together? Nobody else is freaking out like you're freaking out. If you just had a better attitude, things would work out for you, okay? When that's the message that they're getting, and this is like I can't remember who said this before. I think it was Susan who said, it's constant now. You're constantly getting feedback about, am I responding the right way? Am I behaving the right way? Am I thinking the right way? And we get a lot of invalidation from our environment, all right? When you have that, those two things come together in such a way that the person doesn't trust to be able to identify how they feel or to be able to regulate their own emotions successfully. And so they depend highly on other people to tell them, how should I feel and how should I behave? Okay? So you can imagine if you care for someone and they're your one safe haven and they're the person who's going to help you regulate your emotions, how scary it might be to lose them. Right? And that's that fear of abandonment. Right? Okay? So all of our DBT work really does assume that the biosocial theory stands. Right? But we don't actually have a ton of research evidence supporting it. Okay, this is just something that people are doing recently. So if we assume that the biosocial theory stands, then it would make sense to include the caregiving environment in treatment, because you need to not only educate parents and caregivers about the biological vulnerability, you also have to help parents increase validation and dialectical thinking, and then also help the teens and their caregivers learn to communicate in a way that's more dialectical and validating, right? But we started asking ourselves, do we really know if kids with BPD are more reactive to invalidation, right? Because everybody receives invalidation. And do parents of teens or kids who are at risk for BPD, do they struggle to validate their kids more than other parents, right? And is there a direct link between validation and invalidation and psychopathology? So Megan McCallum took the lead on this research project, and she did a lovely job. And she ran actually 2 studies looking at these questions, right? And she focused mainly on mothers and daughters. So she looked at dyads of mothers and daughters. The first study was titled Adolescents' Emotional and Physiological Responses to Maternal Invalidation, and the second was called Parenting of Adolescents Engaging in NSSI, a multi-method, multi-informant investigation. The first study was lovely because it really measured psychological distress in 2 ways. First, just asking kids, how are you feeling? Subjectively, how distressed are you? Okay? And also objectively getting measures of distress by measuring high-frequency heart rate variability. Basically, they had them kind of all hooked up in the lab. Okay, so 2 forms of measuring distress. And the hypothesis was that relative to healthy controls, adolescents with a history of NSSI, remember NSSI being a precursor to BPD, that they would demonstrate higher sensitivity, so higher arousal levels at baseline, more reactivity when presented with a stressful event, longer time to recover, so a prolonged emotional response following invalidation, and that validation from a mom after they became distressed would help decrease that reactivity. Okay? And again, looking at both the heart rate variability as well as subjective report. So Megan was able to recruit several dyads, some from camp, which is where we were, and some from the community as well as from the Emory Child Study Center. And none of the mothers who participated had been in DBT training previously, so these were just moms who had never participated in a DBT program. And the group, the healthy control group, did not have a history of self-harm. Okay, so we're looking at 14 to 18-year-olds here. All right. So 24 with a history of self-harm and 29 dyads that were healthy controls. Okay. And what did we find? So according to self-report, so this is what the adolescents are reporting, relative to healthy controls, adolescents who have a history of self-harm do display heightened resting arousal. So they are reporting more sensitivity. They are also reporting increased reactivity. Now, bless you, there was no differences in initial recovery. Okay, so the first 2 pieces of the biosocial theory, at least, were held up here subjectively. Okay, the interesting thing, and maybe I should back up for a second. So what Megan did in the laboratory is she had the mothers tape 3 responses. So they were recorded: a validating response, a neutral one, and an invalidating response. Okay. And we asked the adolescents, please think about a very negative, painful, stressful situation. And then we would play back the mother's voice giving them an invalidating response along the lines of, this isn't really such a big deal. Everybody has a bad day. Okay, you really just need to get over it. Okay? And we measured to see what their heart rate did, what did they say subjectively, right? What were they experiencing? And then watch them calm down. Now, what we also looked at is once they were calm, they heard the mother's voice again. In this case, they either heard the mother making a validating statement, right? I understand how you're feeling. That sounds like a really rough day. Or something completely neutral about the weather, okay? The kids who really struggled with NSSI and emotion dysregulation, hearing the mother's voice, period, prompted a reaction. Okay? Didn't matter if it was validating or neutral. They didn't want to hear mom's voice at all. They just were like, I'm out. So versus the healthy control group who seemed to find the validation very nice. Okay? So I can't remember if it was you who raised your hand earlier today. You mentioned sometimes you try to go in with validation and nothing. You're just not getting anything. Right. Right. So it really did make us think maybe there needs to be, once somebody is very, very high on reactivity and they have already perceived invalidation, they may need to come down quite a bit before they can get any more of that validating feedback. Okay? All right. Now, even more interesting to me, because this is not what I was expecting, there was no group differences in heart rate variability. None. So when people reported that they were upset, their heart rate indicated that they were in fact upset. But the kids who were self-harming, their heart rate variability was no different than those of healthy controls. So it's the perception, right? Their perception of distress is more important than objective physiological measures of distress. Okay, so that was the first one. So then the second study that Dr. McCallum came up with, this one was also very interesting. What she had, well, I'll go to that part in a second. She wanted to explore this idea that maternal validation is something that, first of all, that kids could report on objectively, okay? And we wanted to know, did the parents or did the mothers of children who were emotionally dysregulating, did they invalidate more often? Right? Is that true that these mothers struggle to validate their kids? And if so, did invalidation actually increase the likelihood that their kids would self-harm or that there was a link between invalidation and psychopathology at all? Okay, so that's what we were looking at there. And she did this, she came up with this great idea where she had mothers and daughters, again, healthy controls and young people who were struggling with self-harm and emotion dysregulation, she had them engage in 2 interactions that were videotaped. In one case, they had to plan an enjoyable activity. In the second one, they had to work to resolve an area of disagreement that they had both agreed that they would discuss ahead of time. Okay? And these interactions were taped, and then they were coded by objective coders, right, to determine not only just how invalidating the parent was, but also how validating they were, okay? We also got subjective feedback, so we got how invalidating did you think your mother actually was, right? We also asked the moms, how validating and validating do you think you were? And there wasn't very much consistency between the self-reports and what was objectively coded. And actually, adolescents are not very good at reporting to you how validating and invalidating their mothers actually are.
Well,
okay?
hot dog. You gotta repeat that. I knew it.
And there didn't seem to actually be any group differences. So mothers of kids who struggle with self-harm were not any more invalidating than mothers of healthy controls. Likewise with validation. They were just as validating and invalidating as mothers of kids who didn't struggle with emotion dysregulation and self-harm. Okay? So, does not support the idea that there's a parenting skills deficits among mothers of adolescents engaging in self-harm. Now, adolescents' perception of maternal validation and invalidation, though, that is important, right? So their perception of invalidation was linked to self-harm and to psychopathology. Okay. All right. So, in summary, what study 1 demonstrated was that adolescents with a history of self-harm perceived maternal invalidation as more distressing, according to their self-report, but not psychophysiological reactivity. And in study 2, what we found was that adolescents who their self-harm status is not related to parenting behaviors, positive or negative. Okay. Now, for the sample as a whole, however, adolescents' reports of high maternal invalidation in combination with low validation were associated with higher levels of borderline pathology, suggesting a potential protective role of maternal validation. Okay, so it was a partial support for the biosocial theory. So what that means is, and those of you who know me have heard this metaphor before, I talk about, I have 3 children of my own. 2 of them are twins. I'm so sorry. I'm right there with you. Mine are 6, though. It does get better. Temperamentally, my twins are really different. Okay, I've got one who is just easy peasy, right? Go put on your shoes, puts on her socks, put on her shoes. The other one, go put on your shoes. This sock doesn't feel right. This shoe is too tight, and it's a meltdown for 30 minutes, okay? And she's just temperamentally much more sensitive. So my reaction to her sister has got to be different from my reaction to her. So it may not be a parenting skills deficit, right? But I do need to learn skills to effectively parent who I call my orchid, because I think of kids as being on the spectrum of, you've got your dandelions who grow anywhere, it doesn't matter. Sometimes even when you try to get rid of them, they keep growing. You've got your daisies who are right in the middle, right? And they need an adequate amount of water, nutrients, and sun to grow and flourish. And then you have your orchids. And if you treat your orchids like you treat your daisies, what happens? They're going to die. They won't flourish. Okay? So I'm sure there are many people in the room who have orchids, right? I know I do. Okay, so despite the absence of group differences in parenting behaviors, we know that really what we need to do is decrease invalidation, increase validation, right? And that's for not just kids who struggle with self-harm and emotion dysregulation, but for parents in general. And some of this may be also goodness of fit, right? And lots of parents have told me, I parented my 3 other kids like this, and they came out just fine. I don't understand why this child is struggling, right? It's because those skills, that skill set may have worked with those other kids and may not work with this one, okay? We also may have to do a little bit of work on helping adolescents be able to accurately identify times when parents are making an effort to be validating. I think that's also important. Okay. All right. So we did that. So I'm not going to go into DBT, the model of DBT, because somebody else is doing this after me, and I would rather tell you a little bit about skills training and how we've looked at different ways to implement skills training. And before I do that, I'm going to jump to the empirical findings for DBT, because there was one study that was published more recently that I think is really critical. And it really looked at what is it about DBT that helps people get better? What is it? Right? Because you've got individual treatment, you have the skills training, you have the coaching calls, you have the consultation team. So what is it? What's the most important piece? And what we have discovered, even though we thought it was certainly going to be the individual work, right? It's not. It's the skills training, right? So if you cannot get the full package of DBT, at least get the skills training. Okay, so full standard DBT or skills training alone outperforms individual DBT. That skills training component is critical. Okay. All right, so we know, even though we don't have as much evidence supporting DBT for adolescents, that it does in fact work well for adolescents who struggle with borderline personality or other forms of really pervasive emotion dysregulation. And Walking the Middle Path is the module that has been added to DBT for adolescents that really helps incorporate parents into the skills training, right? And helps them not only just learn the skills, but also model the skills effectively for their kids and be more skillful in the way that they interact with their children. Okay? So I'm not going to go over dialectics and validation because we already did that. Okay, and how much time do I have? Do I have enough time? Okay. I've got enough time. Okay, perfect. Okay. But what I will say is that one of the things I really like about the Middle Path module is that it includes dialectical dilemmas for families. Okay, so we've got excessive leniency, authoritarian control. So remember, you have these two extremes that you're working to balance, right? And we work to balance dialectical dilemmas as individuals, but also as parents. So we're working on helping someone understand what are the rules of the house, what are the expectations, what are the consequences when I don't follow the rules or don't meet expectations, and having some predictable rules and consequences and expectations are really important. However, parents who really clamp down and control their children often see very negative results. It makes sense, though, that sometimes parents would want to clamp down and control their kids, especially when they watch their kids and see that behaviorally they're out of control, right? We tend to clamp down. Other times, parents feel like they're walking on eggshells and they're excessively lenient. I don't want to set any rules. There can't be any expectations because my kid is too fragile. Or they'll get mad, they'll throw a temper tantrum, they'll self-harm, they'll become suicidal. And so there's almost this fear of rules, expectations, okay? So we help families get more in the middle. Okay? Normalizing pathology versus pathologizing the norm. Kids who start a DBT program, this is not just normal adolescents, right? This isn't the typical stuff that we see in adolescents. They're struggling, they're in pain. Right? And we want to be careful not to go too far to the other end of the dialectic and pathologize things that are actually pretty normal. My favorite email from a parent one time was an email about how really on my agenda, we needed to prioritize cleaning their room because their room was a mess. I was like, okay, probably her room is a mess. That is probably true. And that doesn't fall within our bucket of pathology, at least not for this particular case. I have gotten a couple where the room was in such a state that it was really a health hazard, but this was not the case, okay? So not pathologizing things that are pretty typical for adolescents and also not dismissing things that are really quite painful. Fostering dependence versus forcing autonomy. This one I see especially with my young adult population because these are kids who are right on the brink, right? So normally, by the time they hit 18, 19, 20, you want them to be practicing a skill set to help them launch and live independently, okay? And parents really struggle because these kids are struggling to either swing from one side of the dialectic where they hold on really tightly and say, you can't do anything on your own, you're not ready, I'll do it for you. I'll make your appointments, right? I'll fill your prescription. I'll give you your medication. I'll call the school and let them know that you need to take a medical leave. Versus forcing autonomy, which is, look, you're 18, you need to get it together, you're on your own, okay? So again, wanting to be right in the middle, wanting to be able to say, you can take on more, and I'm also here to help guide you if you need guidance. And that's, I think, a really tough balance to find. Okay. We talked earlier a little bit about validation. So again, I'm not going to spend as much time here, but I do always like to say, sometimes the best way to understand validation is to understand what it is not. So validation is not reassurance. It is not praise. It is not talking about your own experience, teaching logical thinking, or problem solving. Those are not validation. Okay? So to give you an example, I have my oldest daughter who is 9. She said, "Mom, my 2 best friends, Sybil and Caroline, I think they're drifting away from me, and it makes me really sad." What could I say to her that would be reassuring?
That's probably just something going on with them and everything's going to be fine.
Right, it's going to be fine. I'm sure they'll come around, right? What could I say that would be praise?
Oh, but you're such a nice person.
That's
Why would I
right.
want to be your friend?
Exactly. You're great. You're so much fun. She is, right? How about talking about my own experience? When I was your age, or I remember when my friends weren't paying attention to me and how hurtful that was, right? Teaching logical thinking, I have to be really careful with this one as a CBT therapist because I was trained first in CBT, is now what evidence do you have that is there another explanation for their behavior, right? And then problem solving. Which is, well, why don't you ask them? Why don't you talk to Sybil and ask her if there's anything, right? I'm sure I could come up with a list of good ways to problem solve. So what would be validation? Yeah. Very nice level 3. Yeah. Okay. Or, yeah.
Recognize that you are feeling this way?
Yeah. I could see why that would make you sad. It's hard when friends drift away from us. Okay? Mm-hmm.
Can you go to this after you validate?
You can, but what I would do is I would wait for them to ask. Okay, so I have to really bite my tongue because I want to go right to it. So she will, and she does it. If she doesn't need anything else from me, that's the end of the conversation. And then we're talking about what we're going to have for dinner that night. What should I do? Oh, she will ask me. So she will say, so what do you think I should do? Or did this ever happen to you when you were my age? Or do you think I'm a good friend, Mom? Kids are actually pretty good at asking for what they want from you. So start with the validation, give them some space to then say, I need your help with this. Right? If I'm not certain or I'm worried that she might not be asking for the help that she needs, I might say, is there anything that I can help you with? But that's all I do. Okay? All right. So that is what validation is not, and I think that can be helpful to just keep in mind. Any other questions about that piece? No? The other piece that I will say is to just remember, in the same way that we ask everybody to have compassion for their kids or for if you're the provider for your patients, also have compassion for yourself. We all invalidate, every single one of us, okay? So just to give you an example, I'm sitting in my living room one morning and all 3 of my children come screaming at the top of their lungs into the living room, and I looked for blood. My heart was racing. I thought surely someone had lost an important limb. What's wrong? There's a fly in my room. And my response, rather than saying the validating nice therapist thing, which would have been, oh, I could see how that would be scary. That's, flies that get in your face. Unless you are on fire, you cannot scream like that again. That was my nice and validating response. Okay, so we all invalidate. So the idea is not to get it perfect. Know that, though, for these kids, they need just a little bit more than the average kid. Okay? Behaviorism is also taught in Middle Path, and that's because, again, and anybody who, even if you don't know what it feels like to have emotion dysregulation, I bet there are many people in this room who know what it feels like when you're anxious, all right? Feeling anxious. We feel anxious because we don't know what to expect. We don't know what's going to happen next. So if your adolescent is anxious, it's going to help them to know, what do my parents expect of me? What do they want from me? And if I can't do it, what are the consequences going to be? So good dose of behaviorism. We teach that in Middle Path as well. Now, sometimes in addition to skills training, families get involved in treatment in other ways. So sometimes you need family systems therapy, right, to figure out, how does this affect the entire system, not just this one individual? Or how is the family system maybe making it difficult for the person to really engage in therapy? Maybe it's needing to learn a new set of skills for parenting, in which case we might recommend some parent guidance. Maybe it's the relationship between the parents that is really at the heart of it. And sometimes really people need a little additional support in marital therapy. And sometimes caregivers need their own therapist, right? It's not easy to see someone that you love struggle. Okay? All right, so when you do skills training, the original way that skills training was developed by Miller and Rathis was in multifamily groups. Has anybody participated in a multifamily group before? One, two people, three. Okay, so not that many. Has anybody participated in what are known as parallel groups, where the teens are in one group, parents are in the other group? Okay, also, okay. Well, originally, skills training was developed to include both the teen and the caregiver in the same group. Now, it doesn't always work that way, right? So if your child is in an inpatient or residential setting, that may not be possible, okay? Or sometimes just for logistical reasons, it may not be possible to participate in a multifamily group. In fact, at Emory, when Dr. Ritchell and I first started working with families, we had originally just had an adolescent skills training group, nothing more. We didn't even have a parent group. And then once we started reading the literature, this is before Miller and Rathis came out with their book, we decided, okay, we've got to include the parents in the skills training. We just cannot not include them. So we told our adolescents, okay, we're going to start having your parents come in. How well do you think that went over? Not well at all. They hated that idea. So instead, we had the parents join us, but in a different room, 2 different therapists co-leading that group. And then at some point, we decided, okay, once we kind of wrap up with these kids, then we'll put everybody in the room together. Well, then it was the parents who didn't want to be in the same room. They're like, no, I need this time to feel validated and supported by other parents. I don't want my kid to be in the room. So we worried a little bit. We thought, well, is this even helpful if we're not doing it the way they said we should do it? So we started collecting data, and we found that people were actually benefiting from the parallel groups. So then we thought, okay, well, maybe we need to take this one step further. What happens if we open up a few more groups, and this time we'll open up a few multifamily groups, and then we'll compare them? And so then Colleen said, oh, I'll do that study. So she did. This is Colleen Capworth-White, who's at Duke now. And so she actually took a look. She said, okay, let's randomly assign people either to the parallel groups or the multifamily groups. We'll get pre-test and post-test data, and we'll get self-report measures. We'll look to see how well they learn the skills. We'll see whether or not they like it. Do they drop out? Does self-harm go down? Suicidality, hospitalizations, and then we'll know if maybe one has an edge over another. Now, it isn't randomized control. We didn't have a placebo group, but it was a good naturalistic kind of clinical approach. So that's exactly what she did, okay? And what she thought was, okay, well, hopefully everybody will get better. So we were going with that. That was our hypothesis, right? So it doesn't matter what group you're in, people are going to improve. However, since really this treatment, this method was developed to be multifamily, right, we're going to go ahead and assume that the multifamily group will do slightly better than the parallel groups. That's what she thought. I did not think that. But she thought, This was really very hypothetical because we just didn't know. But I had been running the parallel group, so I probably, had a dog in the fight. So 37 adolescents participated in our program at camp from 2013 to 2015, and 17 adolescents were enrolled in the multifamily group. 13 of those completed the program in 6 months. That's the duration of time it takes to go through a standard adolescent DBT program. The young adult group's a little longer. 4 dropped out of treatment. In the parallel group condition, we had 20 people enroll. 18 of those completed the entire treatment process and 2 dropped out. And I will just say, the people who dropped out were typically decided at some point to do residential. Okay, so that was reasons for leaving. So what we found is that altogether, everybody did get better. Okay, we had pretty much similar results to quasi-experiments already done previously, and that is the proportion of participants engaging in self-harm decreased, proportion of hospitalizations decreased, number of suicide attempts decreased. In fact, we didn't have any during the 6 months. Symptoms of depression, BPD, dysfunctional coping, and emotion dysregulation, all of those things decreased, and everybody seemed to really get the skill. So their skill acquisition improved across the board, okay, as a group. Now, when we looked at the 2 groups to see if there were any differences, and granted, the N is kind of small here, right, but there were none. They did just as well, okay? They did just as well. So what we got from that is that DBT, the adolescent version of DBT, can be adapted and implemented in ways that can still be very positive. It doesn't have to be strictly by the book, and sometimes we need to make adaptations. And it can be evaluated in a clinical setting. Treatment completion in both the multifamily and the parallel skills training groups was associated with significant improvements in all areas. The multifamily group did not outperform the parallel group condition on any outcome measure. And the low treatment dropout suggests that both conditions are well accepted by patients. Okay. So this is not part of the research study, although I did do some exit interviews because I was curious, what do people like about the skills training group? What do the people who participate in parallel groups, what do they like? The multifamily groups, what do they like? And I also asked some of the providers, how about you guys? What do you think? What do you prefer to do? Because I started off teaching the parallel groups, and I love them. I did the adolescent group for a while. They are hilarious. They are so funny. It was like the highlight of my week. I loved it. And then I did the parent group, and I had a great time with that too. And I thought, multifamily groups. I don't even, I was not that interested. And if Colleen hadn't really pushed the issue, I probably would have let it go. And then I led some multifamily groups. And there are some definite benefits to the multifamily group. One, for me as a provider, is that I don't have to do a bunch of behavior management. So I don't have to be like, stop touching her. or can you please focus, get off your phone. So parents were there to do that. So I could really just teach, which was kind of nice, okay? The other thing is that you can do great role playing in the multifamily group. And usually I don't have the teens role play with their parents. I have them role play with a different parent in the room, okay? And it's great for families to see other families who are struggling in similar ways. I think that's very powerful, and the modeling that goes on there as well. The good thing, though, about the parallel groups is that people get a lot of support and validation from each other, right? The adolescents from other adolescents, the parents from other parents. And that is powerful, and I think that's probably a very powerful component of the Family Connections program as well. Okay, so that's a nice piece. Sometimes I would have families where the anger and the animosity between the parent and the child was so high that it was tough to have them in the same room. And sometimes I'd have to split them up. So you sit down there and you sit next to me. So it's like 2 kids who are misbehaving. So sometimes that can get in the way. But overall, I think the multifamily experience was very, very powerful. So I think there are pros and cons to both. Again, I think the takeaway message is that the skills training for both the adolescent and the parents is critical, right? Doesn't matter how you get it. The important thing is that you get it. Okay. And these are just the thank yous, of course, to CAMP, the Children's and Mother's Education Laboratory, and we also got nice funds to do all this research from the Brock Foundation and the Fuqua Family Foundation. So I just wanted to acknowledge them as well. And I'm happy to answer any questions that you have.
That's the time left. Questions? You got the expert.
Yes.
I don't know if you know the answer to this.
Oh, wait a minute. Let's get her on the microphone.
Do you know if self-harm does reduce, say, heart rate and such?
That is a great question. So they have done, so they did one study in Germany, and I really don't know how they got it past the internal review board, but they got it through. It was not with adolescents, it's with adults, where they actually, allergies, sorry, they, they stressed them out, and then they made small cuts with a scalpel. And measured skin conductance and heart rate variability, and it does go down. It does go down. And the idea is very similar to, so for example, does anybody have a blood phobia in this room? No? Okay. Well, if you know anybody with a needle or a blood phobia, you know that it's very different from other phobias. Usually with most phobias, our heart rate goes up, our blood pressure goes up, we shake, we tremble. With blood phobias, what happens is we become hypotensive. Right? Our blood pressure goes down. People faint. And it sounds like for a small percentage of kids, that's exactly what happens with self-harm with individuals, is that they cause tissue damage, and seeing the blood is actually very important. And it brings their blood pressure down, it brings their heart rate down, it decreases skin conductance. So it does actually cause a downregulation effect. Yes.
Here's a microphone.
In your research, what do you think is the underlying cause for these behaviors?
Well, I definitely think that the biological predisposition is key, right? However, there is a transactional effect with the invalidating environment. So I think it's a combination. So I still think that the biosocial theory holds up, right? But I think the important thing is that before, it used to be very much, the parents are doing something wrong. And I'm not convinced that that's the case anymore. And I don't think most people are convinced that that's the case. I think, first of all, you get invalidation from in multiple arenas. Right? And these kids are, and all kids get it, but these kids are just really sensitive to it. And I also think that they need a little bit more in their family life. They need more validation. They need less invalidation than most kids need. It's not that the parents are doing something wrong in their levels of validation or validation. It's just that these kids need more of those skills, right? Or maybe even a slightly different skill set in setting rules. Okay.
You think trauma has anything to do with it?
Yeah. There's nothing, trauma. See, he asked if trauma has I do. So there's nothing more invalidating, I think, than trauma, but we also know that kids are really resilient. So it's interesting because, for example, with the child sex abuse research, we know that one of the things that will predict how resilient kids are to that kind of trauma, which can be very devastating, is whether or not they are believed and then protected, right, by the adults in their life. If the adults in their life believe them and protect them, they tend to do okay. Yeah.
What about an adoption?
Ooh, that one's a tricky one because some of it depends also on when they were adopted, right? So some kids really struggle with developing good attachment, and they didn't learn that from a very young age, and I can't remember. Jenny, you mentioned this. It's like language, right? So when kids are really young, they pick up a language really easy, And as they get older, and you know this if you've ever taken high school French, for example, it's tough, it's hard, right? We don't have that flexibility. I think for some kids, if they don't get those really positive early attachment experiences, it's really difficult for them to learn effective attachment later on. And I think that impacts the interpersonal element of BPD, as well as the ability to regulate emotions and tolerate being alone and not feeling easily abandoned, and that rage that comes with that. Yeah. You're welcome.
Maybe another question, one other question, if anybody has one?
Okay.
Do we know it all?
Yeah.
Okay.
Well, thank you so much.
Cynthia. Appreciate it.